With that, the next paper is implementation of a quality improvement protocol to decrease the length of stay after elective carotid endaretectomy. The authors are from Mass General, Dr. Feldman and colleagues.
Thank you for the opportunity to present our work. We have no disclosures. I'll introduce this QI project with our problem statement. Historically, elective CEA patients at MGH have had excess length of stay. Internal analysis revealed that postoperative hypertension was common, partially attributable to erroneous holding of preoperative antihypertensives. Additionally, urinary retention was prevalent in the male patients with excess length of stay. Here we display some background data. This is length of stay data for asymptomatic CEAs on the top and symptomatic on the bottom, with between 44 and 56% of patients staying inpatient more than one postoperative day, in excess of regional and national benchmarks prior to the beginning of our study period. In collaboration with physician, APP, nursing, and pharmacy personnel, we developed this process map for elective CEAs with process terminals in circles, decision points in diamonds, and transition points in squares. This shows multiple opportunities for streamlining perioperative, preoperative, and postoperative processes, displayed in orange, from the point when patients are seen in clinic through to discharge after surgery. We decided to focus specifically on the increased length of stay attributable to postoperative hypertension and urinary retention. After initial problem scoping and process mapping, we developed our aim statement to reduce the proportion of elective CEA patients with length of stay greater than 1 day from 52.4% towards 35%, in line with national benchmarks. We included all elective CEA patients operated on by MGH vascular surgeons at MGH between February 2022 and February 2023, resulting in 64 patients. We excluded non-elective cases, excluded TCARs, transfemoral cast patients, and extra-departmental cases, for example, those performed by neurosurgery, from the study. Using our process map as a guide, we developed multiple PDSA, or Plan, Do, Study, Act style interventions. First, we developed a consensus-driven preoperative antihypertensive regimen in collaboration with both vascular faculty in addition to pharmacy personnel. Next, we developed a preoperative protocol for dispensing silodosin, which is an alpha-1 blocker, to male patients not currently on alpha-1 blockade. We then developed communication campaigns to disseminate our changes to the inpatient vascular team. And most significantly, we instituted preoperative patient phone calls to relay the new antihypertensive regimen instructions, which occurred between 1 and 3 days prior to the scheduled CEA date. In addition to our target outcome measure of proportion of length of stay, or proportion of patients with postoperative length of stay greater than a day, we developed a suite of process measures and counter or balance measures, including adherence to the antihypertensive regimen for a process measure example, and unattended hypotension for a countermeasure example. Here's a little bit more specifics on our pharmacologic protocols. Most antihypertensives were continued through the morning of surgery, aside from loop and thiazide diuretics and half doses of ACEs and ARBs. This was in response to our pre-intervention internal review demonstrating prevalent postoperative hypertension leading to increased length of stay. Additionally, we started standard preoperative alpha blocker administration in the holding area, as discussed previously. Summarized another way, these are the interventions or process changes in yellow mapped to a driver diagram. Multiple process changes needed to occur to enable streamlining of previously surgeon-specific antihypertensive regimens, increased patient-facing communication and team-oriented communication, and incorporation of a new pharmacologic agent into preoperative care pathways. Moving on to our results. First, I'll start with our baseline target measure and some process measures. For the year prior to implementation of our QI initiatives, the measure for proportion of patients with post-op length of stay greater than a day was 52.4%, as discussed previously. In terms of the other baseline measures and process measures, the patient population was symptomatic nearly 30% of the time, and success on the various process measures ranged from 78.8% to 91.7%. Notably, while 19% of patients weren't able to be reached by phone preoperatively, some were instructed on medication regimen changes in clinic, and thus nearly 90% were adherent to the new protocol. Less than 4 in 5 eligible patients received the preoperative silodosin due to perioperative services being less familiar with this protocol than the rest of the team, highlighting an area for improvement in cross-discipline communication between surgical and perioperative personnel. Urinary retention occurred in 12.5% of the patient population, but did not lead to increased length of stay in this cohort. Moving to our final results, 1 year into our intervention period, we found a reduction in our target measure from 52.4% to just under 33%, a reduction found to be statistically significant. This improvement was present both in symptomatic and asymptomatic patients and more in line with national and regional benchmarks. For our balance measures, we found low levels of refractory intraoperative hypotension or postoperative hypotension requiring ICU admission. In summary, we developed a consensus-driven QI protocol design, enabling smooth rollout of multiple PDSA interventions based on pre-intervention process mapping. Our interventions centered on increased provider communication and patient engagement, most importantly. 1 year after institution of our protocol, we observed nearly 40% lower rates of excess post-op length of stay, bringing our institution in line with national benchmarks for this measure. We hope to embed these protocols into the institutional standard practice into the future in order to hold the gains a little bit better. With that, I'll end and open for questions.
Yep. Dr. McGee.
Greg McGee from USC. Congratulations on your talk, and thanks for bringing it to this meeting. And it sounds like you had great success with this performance improvement project, so congratulations. I think this is exactly how we should be using VQI data to improve our practice. We did something very similar at our center and in our region. And so my question is, one thing we found was very helpful was just not putting Foley catheters in anybody who's getting a carotid endarectomy. That alone helped decrease urinary retention. Do you guys do that, or?
Yeah, we actually, to reverse the typical IHI-inspired QI paradigm of always doing your process map first before you think of solutions, we had thought of, let's reduce our Foley catheter usage. That's probably contributing to things. We actually found on internal review that very few patients were actually getting Foley catheters, and most already had sort of a practice of voiding before the OR. But I think in institutions where that's more prevalent, that would be a huge target.
Yeah, it was a really nice presentation. You know, one of the things on this is that, are you going to expand this to other disease processes? Because if you ask the majority of people in this room, they'll probably say elective carotids go home the next day. So we're talking about kind of hours of discharge. And, you know, you're an institution where people may be traveling great distances to come to you to get it done at MGH. But, you know, I think doing it and carrying it out to other disease processes, lower extremity bypass would be great to see, because I think that's where you can make a big bang for the buck. And the other thing is that with the Foleys, I mean, that's a VQI study that Dartmouth published many years ago, right? On you don't need a Foley in carotid patients, right, and it does add to morbidity. A really nice job, but it'd be great to see it, you know, translate down. So a lot of work was done on it, but you got the process in place to carry it on to other disease pathologies.
Thank you. Yeah, I think I appreciate your comment, and in terms of your question, that's definitely an area to expand to, because most of the interventions we did are not specific to carotid. You know, it's awareness, it's team communication, it's patient engagement. Unfortunately, calling preoperative bypass patients would add a significant amount of workload to our administrative team, so we kind of started with this pilot, and if we can embed that into staffing in the future, I think that'd be a great idea. So thank you.
Additionally, if you can comment, who was the process owner of this quality improvement project, and was there any resistance in the organization? And I mean, you improved it significantly, but you're still, I think 35% are still staying beyond 1 day, and only 10% did require ICU admission. So there is still an opportunity there. So did you identify any resistance points, and who was the process owner? Was it an attending physician or resident?
Yes, thank you for your question. So I was the process owner. The project sponsor was Dr. Nicolaus Zacharias at MGH. But we really had sponsors all the way through, and I think that's a huge lesson for QI projects in general. We had sponsors in anesthesia periop, nursing, and then an additional faculty from the vascular staff. We ran into a little bit of resistance, mostly from the perioperative team in implementing the Rapaflow or Siladocin preoperatively. It was a new medication. We actually kind of had to add it to the formulary, which was one step. But then because of the unfamiliarity, a lot of people just sort of blocked it in the pre-op holding area, which at 6 in the morning is tough to overcome. So I think it's a lesson in continuing to pre-wire. I think that's a huge thing, and just get people on your sponsorship spine throughout the institution, or else resistance will definitely follow.
So when you went through and sort of looked at all the reasons why patients were staying later, I'm sure you looked at like sort of each individual patient. What percentage were made up by these sort of two, urinary and hypertension? Because we're actually conducting a similar one at Stanford right now and found that the biggest driver for us is patients who like need concomitant procedures or something like that, or are admitted for another problem and then we're consulted for a carotid and deal with it at the same time.
Yeah, thank you for your question, Dr. Stern. So to the latter part of your point, we did only include elective carotids, so anyone who was, on the neuro floor or the neuro ICU with a stroke was excluded from this study, and almost certainly that length of stay is greater. And in terms of the internal review, these two areas to target for our PDSA interventions made up a little bit over half of the patients who had excess length of stay. Another big factor was actually rehab placement. It turns out that separate from this intervention, case management was already implementing pre-admission VNA placement and rehab placement for some patients.
Great, thank you.
Good job.
Thank you very much.